Helo pawb, bore da. Croeso i'r ail mewn cyfres hyfforddi a chodi ymwybyddiaeth am gasgliad o gyflyrau sy'n aml yn cyd-ddigwydd mewn unigolion ac o fewn teuluoedd. Cyn i ni ddechrau, mae yna ambell i manylun hanfodol. So, os oes larwm tân, dyn ni ddim yn disgwyl bod yna ymarfer tân, ond os oes larwm tân, gewch chi fynd i lawr y stair tu fas ac ymgynnull heibio'r parasol jyst tu fas i'r ffenest fan yna. Chi siŵr wedi darganfod ble mae'r toiledau'n barod. Mae'r dynion lawr star a mae yna un hygyrch lawr star hefyd a mae'r un y menywod jyst gyferbyn fan hyn. Fe fydd na lluniau ysgafn. Mae Melissa wedi trefnu cacennau blasus iawn a maen nhw gyd yn gluten-free ac yn vegan. Okay, so rhywbeth i bawb. Mae Chanan sy'n eistedd fan hyn yn y cardigan melyn yn fodlon iawn bod yn glist gwrando os ydy rhywun angen siarad neu jyst angen eistedd yn dawel gyda hi am unrhyw reswm. Mae yna stafell jyst lawr y coridor tu fas. Felly os ydych chi angen hi, jyst cerwch mas a nodwch iddi hi bod chi angen hi. Dyn ni yn recordio hyn. Hwre, mae'r technoleg yn gweithio heddi. Felly mae pobl ar y we yn ein gwylio ni hefyd. Helo, croeso i chi hefyd. Dyn ni yn gobeithio gorffen o gwmpas tua 1:00 PM, falle bach yn hwyrach gan bod ni wedi dechrau bach yn hwyrach. Ond os oes rhywun angen gadael cyn hynny, wrth gwrs popeth yn iawn. So, Credu sy'n trefnu hyn heddi. Maen nhw'n gweithio gyda gofalwyr ddi-dal ar draws Ceredigion a Phywys, yn ogystal â gofalwyr ifanc yn Wrecsam, Dinbych ac Honwy. Dyn ni'n aml yn clywed gan rhieni a gofalwyr cyn lleied o ddealltwriaeth sydd o'r cyflyrau dyn ni yn trafod yn y gyfres yma a'r effaith ceir ar eu teuluoedd hefyd. Mae'r gofalwyr yma moyn i ni ddeall sut mae cefnogi aelodau o'i teuluoedd a nhw eu hunan. A mae'n bwysig iddyn nhw teimlo bod gweithwyr proffesiynol yn eu bywydau yn clywed ac yn deall. Dyn ni hefyd yn clywed gan sawl un sy'n gweithio myd iechyd ac addysg am eu angen nhw i ddeall yn well sut mae'r cyflyrau hyn yn effeithio. A'r gobaith yw y bydd y sesiwn yma felly yn buddio pawb. Felly gyda cefnogaeth ariannol gan y loteri a ynghyd â chefnogaeth y bobl sy'n lliwio llys ag adlamedd, dyn ni'n hapus iawn croesawu Lisa Bown a bydd Kim Clayden hefyd ar y sgrin. Maen nhw'n dod o'r Hypermobility Syndromes Association a maen nhw wedi dod i siarad am sut mae'r syndromau hyn yn effeithio a sut sut rydyn ni'n gallu cefnogi pobl sydd gyda'r cyflyrau yma. Diolch yn fawr. Mandy.
I don't know if I can do the glasses and the headphone. So welcome everybody. So this is the second in our series of training and awareness raising sessions about conditions that we see very often occurring together in families. So first things first, bit of housekeeping. Fire exit is through here, down the stairs, out the front of the building and meeting by the parasol on the corner. We'll have a break in the middle of the morning. I'll leave that up to Lisa to decide when. We've got teas, coffees, etc. And there will be cake, which is vegan and gluten-free. Yeah. Toilets, the ladies' toilets is out here in the corridor, gents is downstairs. We're not expecting a fire alarm today. We've got, we've got Chanan here with us today, who's come as a kind of supportive listening person. So if anything comes up during the morning, you want to talk to somebody about it, she's here, you can grab her, and there's a quiet room next door that you can go to with her or on your own if you want to. We'll be sharing the recording, thanks to Luke for coming and helping us with that. So that will be coming out to you after the session. So I work for Credi. We work with unpaid carers of all ages across Ceredigion and Powys, as well as young carers in Wrexham, Conwy and Denbighshire. So if you want to find out more about us and what we do, please speak to one of the team during the morning or after the session. We've got Jamie, who works with young carers, and Tracy and Carol at the back there, who work with adult carers. If you want to talk to anyone, we've got some information here on the side as well. So we noticed that we've heard a lot from parents and carers how poorly understood hypermobility and some of the related conditions are, and the impact that they can have in a family. The parents and carers wanted to know how to support their family members and themselves, and to feel heard and understood by the professionals in their lives. And we also hear from professionals from health, local authorities and education about their own desire to understand these conditions and how best to support individuals and families. So with the financial support of the lottery and our People Powered Wellbeing project, we're really happy to welcome Lisa Bone in the room and Kim Clayden online from the Hypermobility Syndromes Association to talk about how these syndromes affect people and what good support can look like for individuals and their families. Thank you. Welcome, Lisa.
Brilliant. Thank you so much for inviting me and Kim today. We're absolutely thrilled to be here. We'd like this session to be interactive for some of it, but just share what you're comfortable sharing with. Never do more than you feel comfortable with. So we're aware we're starting a bit late, so we will try and keep to time, but I think we are going to overrun now. But thank you to Luke and Pete for their massive help sorting out all the tech gremlins. Very much appreciated. And so let's get going. Kim, could you flip onto the next slide? So very quickly, because we are running late, I'm not going to go into this in lots of details, but we're going to try and run through a quick overview of hypermobility today, some of the things that aren't talked about so much and that you might want to be aware of from a practical point of view, and then looking at the range of hypermobility syndromes and what you can do to support you or your family members. Before we get started, and only share this if you want to, how many people here are supporting someone that's hypermobile? How many people are hypermobile themselves as well? Okay, yeah, because what we often find is that it's often the mums and the dads, particularly the mums, have to say, that discover that they're hypermobile when their children are diagnosed, and lots of things that they've kind of noticed all their life suddenly make sense. And I have to say, one of the reasons that I'm interested in hypermobility is because I didn't know until I joined the Hypermobility Syndromes Association. I saw the job ad and I thought, oh, I can do lots of those things. And obviously there was a lot of hypermobility in my family, and all these things that were really frustrating as a kid, you know, the falling over, the being good at swimming but terrible if there was a rounders ball heading towards me, and however hard I tried I just couldn't hit it, all of these things. So, you know, and the constant clumsiness and catching my sleeve on the doorway, all these things which I just thought was me, suddenly became clear. And actually I was born with slightly wonky feet and wonky hips, and had I known a lot earlier, now I'm not as young as I once was, it would have been really helpful to have known that there were some very simple things I could have done, like muscle strengthening and Pilates, and, you know, things that I could have done outside of the healthcare system on the whole. and it would have made things a lot smoother, and I wouldn't occasionally have a bit of a wonky right foot. So I'm really pleased to be with you here today, and we'll allow a lot of time for questions at the end. If there's anything that you've got, you really want to ask as we're going along, just stop us. I also wanted to introduce, you can see on the screen, we've got Flick. Flick is our link fairy. She's going to be posting links into YouTube. So if anything useful resources come up as we're going through the session, she'll put that onto YouTube, but we'll try and sort it out. Can we save we'll save the chat and we can share that with people afterwards, so that if there's research or useful documents coming up, we'll share that with everyone that's signed up afterwards. So that's me. And now over to the brilliant Kim Clayden.
Oreda, good morning. Can you hear me okay? Because we haven't checked the speaker. Cool beans, excellent. So hi everybody. Thank you very much for having us here. So just a very brief introduction to me. Within the HMSA charity, I am known as the professional education coordinator. So I actually started off on the patient side of things after being supported by the HMSA myself. I then decided to become a volunteer, and I was a support group leader back in the day for actually quite a number of years, probably about 5 years or so. And I took on the role as well as social media manager, and I did that as well for that kind of duration. And then I shifted over to the professional side of things, and that's what I've been doing for another 5 or so years. So I've been volunteering for the HMSA for over a decade. It makes me feel my age, but anyway. But before all of that, I was actually an ice skating coach, weirdly, completely random, I know, until about 7 or 8 years ago, where I retrained and I became a solution-focused psychotherapist and clinical hypnotherapist. And since then, I kind of hopped over the fence from the volunteer patient to professional side of things, although I feel like I sit in the middle more so because I am a patient and professional, and I help educate professionals and patients for like events like this as well. But I do mostly for the charity. I support the professional events like this, training professionals, because we need them to be aware of these conditions more and more. Because it's quite complex, there's a lot going on for us. But I also support the medical advisory group as well for the charity. And my practice is a completely 100% online with clients from my floaty home. I live on a narrowboat and generally travel the country, which is kind of cool too. And I'm been diagnosed with a multitude of conditions, and some of which we will actually be discussing today. And before we get cracking, I was hoping you would join me in a little poll, or if you will. We're going to do a little, hopefully it's going to pop up for us. Going to do a little, what is known as a Slido. We want to make a little word cloud. So I know some of you may be either symptomatic, hypermobile potentially, and some of you may not. But when you hear the word hypermobility, what springs to mind? So for those of you that have a smart device, you're welcome to use your camera and point it at the QR code, and that will send you to this particular site, and you can type in your words and join the poll that way. If you are unable to do that, you can go onto a browser and you type in slido.com, so SLIDO.com, and then you just type in the number 2802 880, and then you can join us that way and type in those words. So for a lot of people, when we've done this previously, there have been some kind of hotspot words, but it would be great if you could join us and put in some words for us. We've got a couple of people joining us already. A lot of people tend to put the word pain. That's quite a common one when it comes to hypermobility. What we got going? Very flexible. That's a good one. Yeah. Bendy. And I'm very aware there's a little bit of a delay potentially between me talking and what I'm seeing and the kind of the interaction. So I'll just hang fire for a second before we crack on. Bendy, love it. Lack of understanding, absolutely. Double jointed chronic pain. Oh, look at this. Double jointed popping up a lot. Yeah, it's interesting, isn't it? We think of hypermobility and we've probably been told we're double jointed, even though that's not actually the case. We still have the one single joint. It's just extra flexible for us, and in turn causes a lot of pain. Subluxations, we'll talk about that a little bit today, but for those that don't know, subluxations are partial dislocations, so where the joint kind of just sits out of joint. There we go. Thank you so much for joining us on this one. This is brilliant. So yeah, so with the word cloud, I really enjoy this because I think it's good for us to have a little think about where we're coming from, who we've got within us, and it looks like a fair amount of bendy people. Okie dokie. So hypermobility, in a nutshell, we'll be talking about. I will hand over to Lisa, but I'm here with words as well to help her if she needs any support with that. Okay, so right, everybody's kind of done now. That's brilliant. So Lisa, I'm going to hand over to you. I will happily jump in if need to, though. Thank you very much, everybody, for joining us on that one. Okay. There we go.
So just want to do a really, really quick overview about us as a charity, and also to say, because the name of the charity is a bit of a mouthful, we often refer to ourselves as the HMSA. So if you hear us talking about the HMSA in the talk, that's us. So the key thing about our charity is we're here to support everyone with symptomatic hypermobility. So whatever the cause, however mildly or severely they may be affected, and whether they're not diagnosed. So we cover the whole range of conditions that might be connected to hypermobility. So that would be, please flick onto the next slide, sorry. Sorry, I'll come back to that. So we take a solution-focused approach, and one of the things that's really important is we're very, very volunteer and peer and experience-led. We've got 2 part-time employees, of which I'm one. We add up to less than 1 whole person. We have a fantastic band of volunteers. They bring so many different skills. Almost all of them have hypermobility. I would say a significant percentage, and again, almost all of them have neurodivergence as well because of the overlap between the 2 conditions. And what we do is we raise awareness, provide support, and advocate for everyone affected by hypermobility. So we'll touch on this later, but there are a huge range of conditions that interlink or may cause hypermobility. So we go beyond HEADS and EDS. We will cover the whole spectrum. Next slide, please. So yeah, so what is hypermobility? I'm sure lots of you in this room know the answer to this question, but we'll just go through this really quickly. So we've got here about 10% of the population is hypermobile. It's probably significantly more, actually. And if you look at different research studies, it will give you different numbers. And for some people, this is an amazing benefit. You know, if you look at a lot of the Olympic gymnasts and swimmers, they are often hypermobile. Being hypermobile is not the same as having symptomatic hypermobility. So there are lots of people who live without issues. So we are there to support the, minority, but significant minority that do have, issues which are caused by hypermobility.
Yeah, so if I can just add, and it's something we will discuss a little bit later, that it's although we talk a lot about the symptomatic side of hypermobility, being hypermobile in itself doesn't inherently mean it's a bad thing, and it can be an advantage for a lot of people. If you think about pianists, if they can spread their fingers really far, they can get an entire octave on the piano, that kind of thing. And you see a lot of swimmers, gymnasts, musicians, they're all particularly hypermobile, it tends to be. And although hypermobility absolutely can be created in terms of, if you're not born hypermobile, you can make yourself stretch more beyond the normal range, but it is absolutely an advantage, and that was something that was an advantage for me when I was ice skating back in the day. Okay.
And I think it's also worth knowing that there are people who are asymptomatic, as Kim said, who may become symptomatic. So you may be sitting here with family members who are bendy, but at the moment that's absolutely fine. But some of the practical things we'll go through are still worth knowing, because they might still be an issue in the future. Or even if, so for example, my sister, when we come on to the next slide, is hypermobile in a non-problematic way, but did have issues when she went to the dentist recently with a local anaesthetic. So I think some of these things are worth knowing. Should we flip to the next slide?
And hypermobility, you know, it in itself, it's not the same as having the syndrome. So physically too bendy, but when we start to get like a subgroup of people where, you know, it's causing a problem, then we go into a little bit more detail as we move through that. We come with secondary conditions, but hypermobility syndromes won't be their primary difficulty, or their primary condition potentially. So, you know, the example, Down syndrome, and a lot of neurodivergent people, autism in particular, ADHD, we're seeing a lot as that kind of part of their natural makeup as well now, because there's that massive overlap with these kind of co-occurring conditions. So okay, I'm going to go on to the next slide now, because I could talk about bendiness all day. Okay, so just really briefly, we wanted to just go a little bit more in depth as to why it's important to be aware if there's any sort of hypermobility, symptomatic or not symptomatic. So if you've got any sort of what is known as generalized hypermobility, so you've got flexible joints very naturally, and you've not created that flexibility through dance and gymnastics and things like that. So you've always noticed there's this bendiness more than your average bear. So if you have party tricks that you do, bending your joints, like my elbows bend backwards, I used to do it all the time as a kid, and people go, ooh, you know, those kind of things. If you have those things, these are the things to be aware of. So there is this report actually that we get in a huge amount of people that have generalized hypermobility, not even the syndromes, that have this issue around local anesthetic, and being particularly resistant to things like topical creams or injections. So if you've ever gone to the dentist, have a fill-in or any sort of work done, and they do an injection, you may find they start the fill-in and you can still feel it. And those are the sort of issues to be aware of. So before you go, if you ever have struggled with things like that, consider asking for more anaesthetic and potentially more time for anaesthetic to take effect. So it's good that your doctor, your dentist, that kind of thing, they are aware that you have this resistance to local anaesthetic, compared to the general population because of this hypermobility that you have. So some people will also, there's a certain smaller percentage of the hypermobile community that actually are very resistant to the normal local anesthetics they use. So actually they need a different kind of local anesthetic. So if you've ever had that issue where they've added extra anesthetic, they've given you extra time, and you still can feel stuff going on, there's actually another anesthetic they can get you. But usually it has to be ordered in advance for things like dentists. So they must be made aware to get that in time for you to have work done. And so it's ordered specifically for you. They don't tend to keep that sort of thing in stock. So it's just little things like that to be aware of. A little bit of more difficulty, if someone's got their hands in your mouth, having your dentistry stuff done, having taken little breaks is really important, specifically if you've got any sort of jaw or neck issues going on with, you may not be aware it's related to hypermobility, but speaking up with your dentist, having some kind of hand signals is quite good. And Jo talked about this, our lovely resident bendy occupational therapist, because she's unfortunately, with her hypermobility, has a lot of jaw and dentistry issues, and that can be quite common as well in the community. But having some sort of hand signals where you might need to have a break and things like that before you even get started is really useful, because trying to say, I need a break whilst they got hands in your mouth is really difficult. Sounds really silly, but just having some pre-established communication, like left hand means this, right hand means that, can make your whole experience a lot nicer. Anything to add to that, Lisa?
For the carers in the room, if you can sort of be there to support and to agree that with people you're supporting before you go to appointments, that's super helpful.
Yeah, absolutely.
Yes. Kim, I think Kim will be. Could you hear the question, Kim? The gentleman asked, "What about general anaesthetic?"
Yeah, so it's not something that we hear too much about. Weirdly, it's more so the local anaesthetic that we tend to be more resistant to. Although I do know of a few in the community that have not particularly nice reactions to general anaesthetic, but that will depend on the anaesthesiologist and how they're looking after your blood pressure and things like that. But if you've ever had any issues with general anaesthetic, it is good to communicate those, because they may then actually deal with your case slightly differently. But it's not something that has popped up in the community, if I'm honest. But the local is the big thing that we hear about a lot, so that's good.
Ah. Oh, that's interesting. Yeah, no, that's really interesting. I think there's more research about local anaesthetic, so we can't speak to general anaesthetic as much, but it's really useful. And I think if you know that you've had issues with local anaesthetic, it's always a good idea to speak to the dentist or the anaesthetist in advance, just to let them know and just absolutely tell them about past experiences. Wow, no, that's very interesting. That's really good to share. Thank you.
Thank you. Okay. So some people may have noticed that their joints are very, very hypermobile, bendy, but they are not necessarily symptomatic. And that was me back in the day. So many moons ago, and we will talk about this a little bit more if we get some time, but the fact that it can be that advantage for a lot of sports people, musicians. So when I was 19, I actually had a car accident. It wasn't my fault. And ever since that accident, I seem to systematically kind of fall apart. During the car accident, because the way I tensed up, I could see them coming to hit me at the back, in the rearview mirror. I tensed up and it tore both of my rotator cuffs. And then I never seemed to recover. Now, the thing is, with any sort of post-viral fatigue, things like that, we're seeing, and COVID, if people have COVID, we're seeing that as a big one with things like long COVID. But there is this link with hypermobile joints and being more susceptible to things like long COVID, but post-viral fatigue. And then we're also seeing then people becoming symptomatic as a result of a traumatic incident. So things like really big surgeries, we can take longer to recover, traumatic births, any significant psychological trauma even can create this then symptomatic stuff to happen for people. So all of this seems to have this impact from what they know as asymptomatic, so no symptoms, to then symptomatic, and it's having more and more and more problems over time. Sorry.
No, sorry, I interrupted. I think it's also really important to know, if you're looking after young people, that sometimes a significant change in someone's life, so you see someone maybe going from college to to uni, or from primary school where there's a more structured routine to high school, maybe they've stopped their walk to school. Small changes actually sometimes can mean that we have a volunteer who always used to cycle to work, and when she changed jobs and she stopped doing that, she noticed that her symptoms got a lot worse because she'd got that kind of physical support. So I think Link Ferry will probably put the research about long COVID into the the chat. So there's lots of those kind of things, but it can be small changes as well that mean that someone just sees a slight pickup in symptoms.
Yeah, and the fact that you know, for a lot of us, you know, they may have a generalized hypermobility that's been bumbling along in the background, but then this significant event creates this ginormous inflammatory response, and then we become symptomatic. But also, yeah, it's that fact that I stopped coaching, I stopped skating because of this accident as well. Then I deconditioned. That's the other thing, we decondition really quickly, and then causes another host of problems as well. So it's things like that to be aware of. If you know of anybody that you're looking after, caring for, you know, if they catch anything that's created a really big inflammatory response like COVID, for example, and it's not just related like that as well. There's lots of other things that you can get that create that massive response in the body. Then we're seeing this decondition happen, and then potentially becoming symptomatic in other ways as well. Okay, so we've mentioned briefly about neurodivergence and this kind of link with hypermobile in the community, and I have put a link for Link Fairy in the slides for them to put a link to this lovely study. So you can scan the QR code, but we will pop the link into the chat box as well, so everybody can see that. But the main thing is with we have what is known as our Bendy resident brain doctor, Dr. Bendy Brain, Dr. Jessica Eccles, incredible lady, hypermobile herself, and she is a neuroscientist and does all of this lovely research with neurodivergent people. But we seem to be, as a general population of hypermobile people, twice as likely to experience pain on a regular basis from her research. So even if you are not symptomatic, you may still have painful joints and have this kind of inflammatory response. But this research has been quite groundbreaking for us, and a lot of us are noticing some sort of neurodivergence going on as well. So it's definitely been bumbling along in the background for a lot of us as well. So a lot of people have things like ADHD, autism. You may even follow, and the people you're caring for may even follow certain people online, and they are now noticing this kind of link with the hypermobile joints. And what Dr. Jessica Eccles is doing, she does lots of talks for ADHD YouTube channels and podcasts and stuff, and this, she's helping spread the word about this link between them, and we're seeing it more and more research is always being done. But if you are interested in this kind of link, that's the lady to follow. Anything to add, Lisa?
Coming up as well on neurodivergence, but yeah, a lot of the stuff from Jessica Eccles at Dr. Bendy Brain or at Bendy Brain is, I'm sure Flick will put that in the link, Ferry will put that in the chat. There's some really good stuff, and she's publishes a lot of research. So each year she has a lot of papers coming out. She's very active. Brilliant.
Okay, so just some medical precautions, you know, like we mentioned with local anaesthetic, are things to be aware of. So if you're supporting anyone that's even mildly symptomatic or very symptomatic, or for yourself, if you have any sort of generalized hypermobility as well, you know, why we need to be aware of these things, even at different points of life. And some things that you may be able to discuss with your GP. So if you ever sat wondering whether to get a diagnosis, for example, is it even worth mentioning at all? But just having a conversation with your GP and having a little note put on a medical file somewhere that you have this hypermobility is really good, just to have it noted on the notes. So and if you're supporting anybody, having it, getting their medical notes updated with that. You don't necessarily need to go through the whole diagnosis process unless you know, if they are just a bit bendy, but unless they've got other stuff going on that you think could be linked. You know, from today's talk, you'll notice lots of other things that might be going on with them that are actually all interconnected. But if they just have this general hypermobility, it's worth just having it noted rather than taking them through that diagnostic process potentially. But one of the things to think about is the rehabilitation perspective of when you're doing rehab after for injury or post-surgery. just attempting to get fit even. You know, hypermobile people have a real tendency to, we go all in because we feel fine, we do a lot, we do the physio, and then the next day or the day after that, we absolutely feel like we've been hit by a bus and our whole body hurts and we're just crying in pain. And it's this weird kind of disconnect that we can have of how fit we think we are and how fit we actually are, and it just kind of collides and has a few problems like that. So it tends to present in like things like physio, and the physio will assess you as being mildly deconditioned, not too bad, give you a set of exercises, and it turns out the exercises are way too much and way too difficult. And this is something that our occupational therapist resident Jo Southall, she calls it cheat exercising, and it isn't our, you know, it's not that we do it on purpose, it's very unconscious, but hypermobile people tend to have this tendency to cheat with exercises. So, you know, it's not a deliberate choice. We use wrong muscle groups, we hang off joints, muscle patternings are wrong, you know, wrong positions. So we achieve something that looks very vaguely like the exercise that we're going for, but actually we've done something completely random. And to an untrained eye, or not a very great observer, they might miss this, and it's really common because we just make it look like we're doing the right thing. You know, I can put my hands down on the floor, but I'm hanging off my hips as I do it, I'm not stretching, you know, little things like that. So I'm not actually using the right muscle groups when doing exercises like that. I have to be really consciously aware of how I'm moving my body, even sitting, making sure my posture's in the right place. I may look like I'm doing it correctly, but actually I'm probably not using all the correct muscles all the time if I'm not consciously aware of it. So it can put people off doing movement, doing physio, because they do it, they feel horrible, flare-up happens, goes horrendously wrong, and then movement equals pain, and I don't want to touch this anymore. So this is why it's really important that we think about, you know, who is helping us. Are they hypermobile aware, so they know that you're engaged in the right muscle groups, to be aware of all of that. Okay, anything to add on that little bit, Lisa?
No, I think I know Jo also says sometimes if you've got a physio that's not used to dealing with someone hypermobile, maybe do the exercises, but break them into smaller chunks and maybe do a third of what you've been told to do at the beginning. So do the physio, but break it down, do it throughout the day, and start lower.
Absolutely. And then in terms of kind of medications that there is this, it's a really, do excuse me for not pronouncing it probably correctly, but fluoroquinolines, I think, something along those lines. I probably pronounced that wrong, but basically this is a particular group of antibiotics that can have a detrimental effect on the connective tissue. And with this hypermobility, it's the collagen that is faulty, it's that connective tissue that is faulty. So for those of us that have already got any pre-existing rubbish connective tissue, so any sort of hypermobility, it can have a detrimental effect on that and magnify problems. So trying to avoid, if possible at all, is the sensible thing to do. But obviously, if it's standing between you and a life-ending infection, you know, it's your choice to take that antibiotic. But it is things to be aware of. You know, there are many other antibiotics out there, but anything with those ones can really really upset your connective tissue. And this is what's kind of holding us together, even though we are very flexible with it. So you're going to have a really rough time afterwards, and then some rehab will be needed, like physio and stuff, to support you as well, because it can make you even more stretchy. And the next one to think about is the I'm going to get my teeth back in. Corticosteroids. So thank you. So any steroid injections that you may have had or may not have had, often used for things like bursitis and tendinopathies, so tendon problems. Bursitis is like the way the body tries to protect joints when it's really inflamed and angry, and it causes a huge amount of pain for people. They can be fantastically effective, but we can only have 3 per joint, because it starts to essentially break down the joint. So by removing pain, we're actually upsetting the joint and breaking it down and causing more problems. And for certain joints, actually, so as an example, I had a cortisone guided injection on my Achilles tendon. I can only have that done once, because unfortunately the next time the rupture could happen. So being able to have things like that done once, that's fine. But anything like, again, it just increases that risk exponentially. I didn't know this when they did it for me initially. It did completely help, and I could walk again more properly. But if I'd have known, perhaps I would have looked at different options, like different physio and things like that. It's that informed choice, that informed decision. So if you're anyone you're caring for, or even for yourself if you're hypermobile, it's things like this to be aware of. Have you tried physio first? Or are they just saying, oh, let's just stick an injection in and that will fix it? It's not going to necessarily fix it. It's going to help reduce pain so you can do the physio you need to do. But have you tried all those other options? Because we only get so many per joint. So pace yourself, making sure you're stretching out those injections is really important. And Jo, she uses the example of herself with her hips. She has hip bursitis, and she can only have 3. And I think she's on 2 in one of the hips, and she's now like, well, it's starting to get bad again, but I really can't afford to have that last one. I need this to last. So it's trying to do all the other things as well to support it, to try and stop having to need this again. Anything to add on that, Lisa?
No, I'm just conscious of time, so we probably need to move on.
I will do my best to whiz through. So things like any sort of histamine type of responses to things is another thing to be aware of. So medication that disagrees with you can bring you out in hives and things like that. So some hypermobile people can be very sensitized to a lot of things, but there's a whole range of things that we might be actually sensitive to that create a histamine response, and your body kind of gets angry at. So allergies are quite common within the community, and we just need to be aware. If you've tried something once and it's caused a mild reaction, should you try it again, the reaction can increase and kind of stack up over time as well. So if you do have a major reaction to anything, or you'll find that you're really sensitive to a lot of things, it's just something to be aware of. With any level of hypermobility, if there's a small chance that you've had, like I say, a tiny reaction, they call it a stacking effect, actually. So the more you have something, it can get worse and worse and worse. But then if you stop having something for a while, it almost give it a good 6 months, and it kind of falls out of your system, because the reactionary cells, the mast cells, have like a 6-month shelf life. You may find that you can have the odd thing now and again, but when it comes to medications, like some people will have penicillin allergies, absolutely avoid, don't try that with even the 6-month rule. But if it comes in terms of food and allergies, then maybe you can try those things very gently with your GP, for example. Poor surgical outcomes, longer rehab, as we've mentioned, with exercise and rehabilitation after surgery and injury. Heat intolerance is another thing to be aware of, and we'll talk a little bit about POTS when we get time. But heat intolerance is quite common, so you may find that you feel really poorly in the summer when it's really hot, and feel much better in the autumn. A lot of us do, and there's ways and means of kind of managing that as best as we can. But just thinking and about heat intolerance and having a little Google is quite an interesting one for us. And things like gastrointestinal issues, reflux, slow digestive transit, so food taking a lot longer to move down the body through the stomach, is all quite common within us as well. Okay, Lisa, anything to add briefly before we move on?
No, absolutely. And I think with the next slide, with hormones and hypermobility, this is something that if you've got daughters, it's really good to be aware of. We find that there are key moments in you know, a young girl's life moving through to women and then to perimenopause, that you might find spikes in symptomatic hypermobility. So around the lead into menstruation every month, then you've got pregnancy, and then you've got perimenopause and menopause. And so those are things that are really good to know, that there might be a heightened response. And we get so many mums who realise their own symptoms when they're having perimenopausal symptoms. Their daughter gets diagnosed, and it all kind of drops into place. So this is a really good thing that's not spoken about that much, but is really good to know about.
Yeah, and if you care for young people, you know, if they're hitting that puberty, then it's likely they can actually become more bendy and possibly injure more. So it's little things like that to be aware of. And it absolutely happened to me with my skating and the martial arts I was doing. I absolutely could definitely injured a lot more, having to strap ankles up and that kind of thing. So it's the little things to be aware of, that if you start seeing that they are increasing in injury and taking a long time to recover from them, then possibly more investigation and possible diagnosis needs to be looked at. Okay.
You may find this with other conditions, but in the week before your daughter's period, you might find they get more clumsy, and as Kim said, more prone to injury. It's really, and you can probably almost spot it once you know. So.
Okay. So why should we be aware of it? And you know, the signs that it's always kind of been there. So if you've ever noticed any young people perhaps you care for or support, things like sitting in a W position is the classic that you may have seen. When we say phantom bruising, it's bruising and you don't know why. And we know, you know, hypermobile people are very clumsy generally because our proprioception is very poor. And when we say daft proprioceptive stuff, proprioception is understanding where we are as a person in time and space. We are very bad at it because we're so used to our joints doing whatever. We will catch ourselves on doors, trip over our own feet. So this isn't just phantom bruising in the sense that we've done something silly as a daft proprioceptive stuff. This is having bruises and we really don't understand where they've come from. So you may have actually just tapped something and then you get this ginormous bruise. So it's things like that to be aware of. We do injure more easily. Poor muscle tone is a problem for us. So, you know, if you've got a really sporty person that you're caring for, that, you know, they may be really into certain sports, you know, you notice that there's getting more and more injuries. Again, it's that perhaps they need a little bit more of a look into the diagnosis and more support in terms of physio and things like that. They need to strengthen other muscle groups to support the ones that they are using. Do take longer to heal from injuries. Scarring we'll touch on briefly. There's certain kind of scarring that we do see in hypermobile people because of connective tissue problems. And interestingly, when the hypermobile person is doing things in what Joe, our OT, describes as sport mode, we are actually less likely to injure than when we are more relaxed, and particularly when we are asleep. So sport mode, you know, your brain's engaged for the activity, so your body's engaged. But when we are particularly asleep, we are at our most relaxed and our joints are the most lax, and that's when we can actually injure stuff. Sounds really counterproductive, but it happens. I wake up most mornings and my shoulders have been sat out all night, but sitting here, they're in because I'm actively engaging and using them. So your brain's not aware, your body tends to relax and cause then a problem. And things like when we say about swimming, you know, you may be able to swim and swim and swim, but you get into the changing room where it's really, really humid, and then all of a sudden the exhaustion just kind of hits you and that heat intolerance kicks in. So it's little things like that as well to be aware of. Lisa?
I think there's a question in the room. What's your question? May? No, sorry. Kim, could you hear that? So the question was,
Yeah, I think so.
okay.
Yeah, so if you're knocking yourself, you think a little bit, but actually you think the pain response is more than it should be. Is that correct? Yeah, and that's really common in hypermobile people as well. So we have a heightened sense of pain. Now, for a lot of people, it's because a lot of the time they are in pain a lot, and the brain does actually rewire for pain and sends a heightened signal through. Our nerves fire more, brain fires more when it comes to this pain response. And the more, the more we have issues like that, the more the brain's wiring, because it's this prediction machine. So, if you're having pain quite a bit, you whack yourself quite a lot, trip over your own feet a lot, you're having a lot of this going on, your brain keeps wiring to that, and it will sensitize and sensitize and sensitize over time. Particularly as well, if you've got a lot of gut problems and stomach upset, that can even create a sensitivity as well within the brain and the nervous system. It's called central sensitization, and that's something to look into as well. If you think anything like that might be going on, your brain and your gut are so linked. Your brain can actually make your gut can make your brain go into fight, flight, and create more pain. And also, just really, really quickly, stress can actually amplify pain as well. So if you've got a lot going on in your life, and it can be absolutely anything going on, then the more stress you're under, the more pain you experience as well. It's like your brain whacks up the thermostat. So there's that disconnect between what you think it should be and what you're actually experiencing. The brain can turn that up as well.
Thank you, Kim.
Okay. So just very briefly, Lisa, we've got the pictures from Jo that she shared with us before, just the variability.
Right. So I think one of the things about hypermobility is that it can affect people in really different ways. And so it can affect different joints, and people have different range of symptoms, but also it can affect the same person really differently at different points in their life. So that there will be, so this is Jo, who we've been talking about. Jo, the wonderful OT, our resident Benji OT, and she, in different phases, when there are different things going on in her life, different injuries, different health conditions, as you can see from the pictures, it's affecting her in very different ways. So I think, one of the things we'll talk about later is pacing, and it's trying to, remove some of the ups and downs which everybody has in life, but just trying to provide a way of reducing or managing flare-ups a little bit, because people respond differently at different times and in different situations. But great set of pictures from Jo.
And just real
yes,
quickly,
of course.
This is, sorry, go on.
I just want to
So, sorry, it's really hard to hear you. Lisa, can you say that for me?
Can we come back to that question, because it's quite a big one in the Q&A section, because I think we could talk about that for ages, and it's a really, really good question. But I think we'll come, if that's all right, and I'll make sure Kim's fully can hear the question. Is that okay? Sorry.
I kind of catch bits of it, and then the connection's a little bit dodgy. Okay, so the previous bit, that was just a quick video. So this was actually me back in the day. And this was one of the things I was really well known for. So this is, you'll see knees, but also the back, and at one point as well, the elbows as well, particular. So you can see the knee bending incorrectly. I'm actually hanging off my back muscles in a way that is not healthy for me, hanging off my knee joints in a way that's not healthy for me. It was an advantage, but it absolutely was causing injury at the same time. So things like that to be aware of. You may see it quite a lot. We tend to hang off joints and create more soft tissue injury. So there's a lot of aching in joints and things like that as well. So I want to get us moving, because we've been sat here a while. I want to know what your Baton score is. So Lisa, I'm sure you can do a wonderful demonstration.
I can. So is everyone in the room familiar with the Baton score? So it's a score, and we'll come on to its reliability in a second, but it's a score that's often used to test whether people are hypermobile or not. And so there are certain tests. One is the touching the ground flat-handed. There's the elbow going backwards. There's don't do this in case if it hurts. There's the thumb back to the wrist. There's the pulling back of the fingers, and whether your knees extend backwards as well. We were just going to see, and Kim will run through the scoring system because it's terrible, I can never remember what it is, which joints get 2 points, and to see in the room what people's Baton scores are. If this is going to cause you any injury or discomfort, please do not do this.
But it is a good opportunity to get up and have a wee little stretch
and
as
so
well.
even if you only have a wiggle, get up and have a wiggle.
So your little fingers that you pull back, please don't go beyond your comfortable range, but they're looking for a 90-degree bend, and you get 1 point for each little finger. The thumbs that are to touch down onto the forearm, you get a point for each thumb. The bending of the elbows backwards, I don't know if we can see mine at all, but they're looking for a 10% range of bend there at least. And knees, they're looking for 10% as well, and you get a point for each knee and each elbow. And then the one that really will get you moving is your hips. They're looking for your hips as well. So if you can have your legs straight and your hands can go flat on the floor and bending at the waist, you get 1 point for that. There we go. I can see something going on there. People are moving.
Thing is, I'm so clumsy, I'll probably fall over.
Okay. So just bearing that kind of in mind, if you can, I'd like you to join me again and just to pop in your scores. Now, this Baton score was originally created as a research tool, but it is being used more for diagnostic stuff. And there is very much a disconnect between what the score is and what is actually happening for a lot of hypermobile people. But I think it's really good for us to see. Oh, interesting number. Yeah.
Mildly symptomatic, but we've got lots of volunteers who get a lower score who are far more symptomatic, because then it's affecting different joints that aren't covered, unfortunately, by the Baton score. So it's used a lot. It's not without its problems.
Yeah.
Yeah, no, absolutely. And so we'll talk about that later. But one of the questions that should really be asked is not what you can do now, if you're talking to people sort of my age, not what you can do now, but what could you do when you were younger. So because yes, it can be. I haven't stiffened up a lot, but a lot of people do. I have a little bit, and I notice post-virally I get a bit stiffer. But it's not uncommon at all. So it's always good to think about what you could do when you were younger.
Excellent. Okay, so very, very interesting scores up on that screen. So yeah, as Lisa was saying, anything kind of 0 to 3, you're not considered really bendy at all. And yet, as she's described, we actually have one of our volunteers has a score of 1 and is probably the most disabled person that we have within our team. Okay, so going to get diagnosed, getting a score of 1 and being told you're fine, doesn't work for us. And as we've mentioned, as we get older, we become more stiff as well, and we're not actually then able to get diagnosed, even though it has caused us a problem. So if you are over 4 or 5, then you're considered hypermobile. And for children, we're looking at 6+, because children are generally more hypermobile than us adults as well. So if you've ever considered yourself double jointed on any scale, then this is exactly why you would have that 5+ on this scale. Okay. But as we say, it isn't good for a diagnostic criteria for us. Okay. Because it has this whole range of other things that we could potentially have going on. And as somebody quite rightly mentioned, this is now why we have the 5-point questionnaire as well. So it's now thinking about things as a child or teenager when we have our questions done. And you can see the date, 2013. It's actually really not that long ago in terms of medicine, and in terms of the diagnostic stuff that we've had going on for hypermobility. So a lot of people are being dismissed because they've gotten more stiff later in life, for example. They're not hypermobile anymore, so you mustn't have it, you're fine. Thanks. Now what do I do? Okay, so it's really important that we have these other ways of looking for it and testing for it and having the diagnostic stuff for it. And this is just a few of the things that we're trying to use as awareness. And also we're given to GPs and things as well to really look at the other links that are going on with hypermobility. And I think we'll be able to offer the link to this as well
with me if people want to take it away today, and we can show you where it is on the website as well, but I have got a copy that you can take away.
Thank you, Lisa. So one's more medical than the other. These are good for GPs to have. Hand it to your GP, that kind of thing, and put it in your community. That's cool. But there's some key symptoms we might have, and might need a little bit more explanation in terms of the terminology, but your GP should understand them. But equally, it's important to understand that it isn't just hyperextension, sprain strains, and partial dislocations. There's a lot more going on underneath the surface. A lot more for us as well. Okay, that's why the iceberg's quite a poignant one for us. Okay.
Yes, of course.
I have friends that could bend very right when they were. I never did that, but I was quite clumsy and I told them stuff. But now I'm really stiff and I have body pain very short. So could it be that I wouldn't have known as a child, or would it be really obvious?
Kim, could you hear that or not? Because there's also a lorry beeping outside.
So I'm not hearing much at all, sorry.
Oh, it's absolutely fine. So what she was saying was that, I'm sorry, I didn't catch your name, sorry, was that some of her friends were really flexible as a child. She didn't feel she was, but now feels like you've got lots of the related symptoms. So could she have been hypermobile but not realised she was hypermobile as a child?
That's really common. And the thing is as well, if it's in your family, it's just normal, isn't it? Yeah. So if other people have got it.
If
Sorry.
children are hypermobile, it's impossible to say, isn't it, whether that was the case when you were younger, but it wouldn't be improbable, bearing in mind your children are hypermobile, because it often runs in families, that yes, you were, but it wasn't with joints that other people were doing party tricks with in the playground. So that is one of them. So, and that I think comes back to, it's going to be impossible to say, but it does come back to that thing about some joints not being tested. So one of my children isn't very severely affected, but for example, when he was learning to drive, he couldn't take the handbrake off because his thumb was going back. and it never even occurred to me that he was bendy in the slightest. So, it's hard to tell, but possible.
It is really hard to tell, and also, as it does tend to run in families, if you're all hypermobile, it's just a normal thing for you. So you don't pick it up. It's just normal. It just is what it is. It's really hard to know. That's not quite right. And actually being in pain all the time isn't normal, and yet a lot of us are in pain all the time. But that's not, you know, we just think that's normal because that's how it's always been. So being in pain, painful joints, being hyperextending more than your normal range of movement is not normal. And yet if we have a whole family of it, you know, we all look the same, we all experience the same. It's just that's normal. It's really hard for us to pick up. I hope I caught what we were saying there, and I hope that was useful.
Great. Thank you. Great. Thank you.
Okay, so there are hypermobility syndromes. So that's kind of like an umbrella term for all the different conditions that have a symptomatic hypermobility. And that's why we like to use our umbrella for our multicolored umbrella for describing things like this. Now, hypermobility syndromes are, you know, they include a fair amount. We have a couple of the most common ones that we see diagnosed a lot, which is the HSD and the HEDS at the top there. But there are other rarer types, and things like classical EDS, if your skin stretches much more than the average bear, and we're talking the neck stretching right out here, that's how stretchy the skin can be. That's not normal. You know, I have a fair amount of flex to my skin, but I don't have it to that degree. And there's other symptoms as well. Vascular EDS, Marfan's, osteogenesis imperfecta, also known as brittle bone disease, Stickler's, PXE. There's so many more. We mentioned Downs. You know, all of these things. You know, there's this absolute umbrella for all these different sorts, and we know that EDS gets talked about a lot even in our community, but there are so many conditions that the hypermobility is actually the horriblest thing for them to be dealing with day to day in terms of management and pain and fatigue. You know, we want to support all of them. That's what we're here for. And just to kind of Lisa, do you want to talk about our little Venn diagram?
No, I was just going to say, I think what Kim's saying is really important, because I think, you know, we absolutely support people with HEDS, with EDS. That's what we're here to do. But we absolutely want to include everybody affected by hypermobility. And so many people are forgotten or kind of sidelined or put to the side, which is terrible for something when people are feeling lack of validation in the first place. So we absolutely want to make sure there's recognition for all of the various variants of hypermobility and the reasons for it. So there's the Venn diagram here, which probably speaks for itself, with the big number of asymptomatic hypermobility, you know, big circle on the left. But as Kim mentioned earlier, there are also those other conditions like cerebral palsy, like Downs, where hypermobility might be present. So we just really want to make sure we include everyone, and that in a kind of arena where people are already suffering from lack of information, lack of validation, that no one is being excluded.
Okie dokie. So even though somebody is potentially hypermobile, maybe their joints aren't painful at the moment, but you may notice some other things going on. And they might be struggling in other areas, because these are so interconnected. So having hypermobility, it's the connective tissue, it's the collagen is faulty. And you can see from those images, the one at the top is normal collagen, and the one at the bottom is the hypermobile collagen. It is not so good, not so good at holding us together. It's extremely stretchy. So there's actually a lot of other things it interconnects and plays with, including the dental issues we mentioned earlier, joint pain and subluxations and partial dislocations. You know, those are absolutely part and parcel of it for a lot of people, but not everybody. But we do get bowel issues. We get slow gut transit. The food goes really slowly, causes bloating and pain in the stomach, you know, poor wound healing, hernias, bladder weaknesses, pelvic weaknesses, autonomic disturbances. So we have an autonomic system, we have a fight-flight system, and a rest digest system, and it actually can cause this to go wonky as well. So things like POTS, you may have heard of, it's been talked about a little bit more, is very common. It's something else that I have within the community. MCAS is mast cell activation syndrome for those people who have a lot of allergies. You know, it can be anaphylaxis, but not always anaphylaxis. It can be hives and blisters on skin to things. So if I have the sport tape to hold my joint in place, the adhesive, for example, will my skin will blister just from the adhesive. You know, it's things like that cause problem. A lot of food intolerances. There's high prevalence to neurodiversity, causes a lot of fatigue, and we have a lot more anxiety and depression within the community as well. Particularly if there's, you know, you're struggling with a lot of pain all the time, it really plays on your mental health as well. So anything to add to that, Lisa?
No, I was just going to say a lot of the things I think on this list you're covering in future sessions, which is really great. So that's brilliant.
All beans. Okay. Do you want to quickly sort of kind of go
I'm conscious that we started late and we're all in need of a break, I think, but just want to share this piece of research. It's one of my favorite pieces of research. It's actually a diagnostic screening tool. There's a version, pediatric version and an adult version. It's come out of research from UCL and Great Ormond Street. And it really shows that being hypermobile is more than being a bit bendy. And so many people in the room will have experienced, I think, with people they're looking after or themselves, all of the interconnected issues. We can also share the link for this. We've got a blog on this if people are interested. But again, it goes through a lot of those related factors that Kim's just been talking about, and you can map it. So there's a questionnaire that goes with it, and it's a much, coming back to the Batum score, which we were talking about, it's used a lot and very unreliable. This is potentially a really great tool that clinicians could be using to get a much rounder understanding of all of, and holistic understanding of all of the issues and the interconnected issues that might affect someone who's hypermobile. So we just wanted to share this with you because I think this is a really excellent piece of research. Yeah, absolutely. And I'm going to ask Link Fairy. Oh, the other one. Flip. Yes, sorry. No, you're welcome. I think the Link Fairy will probably put this in the chat and the link, and we'll share that with you afterwards. But we've got a blog on that, so you can find it again afterwards. Musculoskeletal. Where are you looking? But I think it's going to be musculoskeletal.
Neuromusculoskeletal, brain and body linkage as well.
I see where you're looking at.
Sorry. Lisa, just aware of time, we've got red flags before the break. Is that okay? Or do you want to break now?
Can people bear with us for 5 minutes more and get to the break, or would you rather break now? It's up to you. 5 minutes? Okay, let's keep going.
Oh,
we all need to have a wiggle and have a drink.
Thank you for bearing with us. Okay, so we'll quickly fly through those red flags. And this is to look at some symptoms that you may be experiencing that would perhaps suggest that some genetic testing needs to be done. Now, for HSD, so the hypermobility spectrum disorder, and for the hypermobile Ehlers-Danlos syndrome, there's no genetic test that can be done. But we are talking red flags in terms of the more rarer conditions that there are genetic tests for. Okay, so just to be aware of that list here. Having some of these things does not automatically mean you immediately you have one of these rare, complicated, scary things. Okay, it's just an example. So for example, joint dysplasia can be a symptom of some rarer kinds of EDS, but like our Jo, our OT, she has bilateral hip dysplasia, but she doesn't have the rarer kind of EDS. And hip dysplasia is just where the socket developed poorly, so causing the ball and the thigh bone to kind of not sit properly, and it will just slide about and move and cause the hips to be really painful. And this hence why she gets a lot of bursitis and talked about the injections for us and gave us that as an example. But it can also be an early onset for hip arthritis and things as well. So To have that doesn't necessarily mean you have a rare one. It can be part of another symptom, but it is something to consider, and it might be worth talking to your GP about genetic testing just in case, to rule it out. And for example, you know, if you're very sporty and you break the occasional bone, for example, you know, that is okay. You know, I did it myself playing football, broke my wrist. That is normal. But if you are breaking multiple bones by doing very little, that should prompt potential genetic testing for things like osteogenesis imperfecta, for example. Okay, so in terms of the soft tissue, the skin, so, you know, we as hypermobile people tend to have very, very soft skin anyway, so soft tissue, and we can have stretchy skin, but we're talking comically stretchy skin, like it's pulling right out here. If you have that, absolutely worth looking into. If you get a lot of bruising, and we're talking about bruises for absolutely no reason whatsoever, you're constantly covered in loads of little bruises everywhere, then that's something to consider looking into in terms of genetic testing as well, because we're then talking in terms of classical EDS and things as well. Okay, so it's just these things to be aware of. If you are very delicate in terms of you know, you just brush against something and your skin pulls and cuts, you know, those kinds of things, all of those things are to be aware of. So I will catch myself, even though I've got soft skin, but I won't tear, unless it's, you know, I've caught something extremely sharp, like a normal response of skin. So it's things like that. If you tear very, very easily by not hardly touching at all, things like that to be aware of. Okay, we've called this squishy bits. That's just the way Joe and I write and talk. So I hope that's okay with you. So the squishy bits on the inside. So if you have an echocardiogram, so they've looked at your heart function, and they say your aorta's got a bit of weird stuff going on, again, worth having some testing done. Maybe that is your choice. If you've got family history of things like early onset family history of aortic dissection, so issues with any of the aorta, aneurysms, big hemorrhages, big bleeds, that kind of thing, big events like that, if you notice and hear of those things happening within the family, again, it's worth getting genetic testing done just to rule things out. If you've ever had a large hernia, particularly if you've got reoccurring hernias, and it's not related to pregnancy, any sort of, because pregnancy can mess up that kind of stuff. But if you're getting hernias before you've even had kids, or much later in life, and it's having to be kind of fixed a lot, you know, it's those kinds of things to think about. Just trying to, hang on, I've lost my slide now. There we go. Prolapses, it's not a nice thing to think about or talk about, but it's where your inside bits try to become outside bits. So things like rectal prolapses, you need to think about genetic testing. If you have any, so even the vaginal prolapses can happen as well, anything like that, uterus prolapses, anything that, any squishy bits on the inside trying to come out, absolutely need to be investigated further, but also genetic testing could be needed to be done as well. And gastroparesis, we have paralysis of the gastro system. So if you're eating food and it's struggling to even come out the other end, or it's not digesting, that kind of thing, your gut is not working effectively, again, it's, you know, further testing is required. Okay, any questions on that? Because I know that, you know, squishy bits are not very nice. But
let's just keep zipping through. But I think most of these things are rare, just to reassure people. So they're not the common things, but they're things to take action on if you spot them.
Absolutely, to bear in mind for, you know, those spotting those things if you're caring for someone in particular. So bones and joints, any significant scoliosis of the spine, so the wiggle in the spine, kyphosis going the other way, you know, particularly at the top of the spine, curves, that kind of thing. It can be indicative of things like Marfan syndrome, or kyphoscoliosis EDS, more rarer types. Again, so if there's any scoliosis, kyphosis, any issues with spines and different, instead of being a nice straight one or a fairly straight one, again, thinking about genetic testing, that kind of thing. So, and joint dysplasia, as we've mentioned, shallow ball socket joints, malformed joints, that kind of thing. any sort of feet, hands, ankles, shoulders, hips, that kind of thing. Anything that kind of moves out dislocates a lot, more than average for a hypermobile person. And then there's something called Marfanoid body type, which can be a bit confusing because it can be found in people with Marfans, but it can also be found in people with certain kinds of EDS as well. But some of the test examples for having arm span longer than your height, which our lovely occupational therapist Jo Southall has. So she has her arm span longer than her height. So she has a Marfanoid body type, but not Marfan. She doesn't have all the other complications and doesn't have Marfan. So it can be a little bit confusing, but you know, sometimes it's good to get tested and see a geneticist just in case. Any issues with kind of your rib cage, any deformities, kind of what they call pectus excavatum. So the chest kind of goes in or points out, any sort of barrel shaped rib cages, anything like that. And then just kind of going through very briefly, eyes as a red flag. If you see very, very bright blue tint to the white of the eye, and we're talking extremely blue, like it's a very obvious, and sometimes people are like, oh, is it? It's a very obvious blue tint in the eye, and that can be some indicators of other things. Subluxations of the retina and the lenses should be treated as a medical emergency. So if you wake up and your vision's gone, so if someone wakes up, vision's gone, you've got to get that absolutely looked into straight away, because my mum had to think about it. It's like, no, you need to actually go to the hospital now with this. This is not good. Any sort of laxity in those ligaments and muscle spasms and stuff can happen even in eyes a lot and stuff. So you know, any sort of things like fuzziness in the eyes, that in terms of vision, some people get a lot of light sensitivity. Doesn't mean you have a rarer type, but you probably need to be seeing your eye doctor a lot more than average, that kind of thing as well. And very briefly before the break, I might leave this up actually, because this is a good one for people to have a little Google. Yeah. I know I need a wee. TMI. But yeah, some of the co-occurring symptoms are really good. Take a picture, whatever, have a Google, because we won't have time to go into too much detail for these today, because you know, hypermobility covers so much, and that is exactly why we do what we do in terms of the awareness. But POTS, MCAS, fibromyalgia we can often get misdiagnosed with, but also it can go hand in hand. Same with chronic fatigue. There are systemic reasons as to why we have chronic fatigue. There's reasons why a bendy person has fatigue, but you can also have things like ME as well. They are separate things. Acid reflux is really common. Irritable bowels, really common. Hernias. Gut dysmotility is that slow movement of the gut. Raynaud's phenomenon, you may or may not have heard of, but if you ever get really cold hands and you're hot, or you get certain fingers that are hot and some are cold, you get this discoloration in particularly fingers and toes. That's quite a common one in the community. Anxiety, depression, and then neurodivergence, autism, ADHD, that kind of thing as well. So I'll leave that up with you, and then you can all disperse for your break. Go.
We'll see you soon. If we can take a 15-minute break, because I know we're kind of already behind, that would be fab. What we wanted to do with the second half, just to have a little bit of a think, because we know that a lot of you are affected directly, or also caring for young people. We just wanted to have a think, and if you're watching this on YouTube, if you just put your feedback in the comments. If you're sitting at a table, there are pens and bits of paper, and there were post-it notes, but they seem to have vanished. Here we go, post-it notes. If you could just have a think about what you found most challenging, either with your own hypermobility experience or in terms of caring for somebody else in your family, and what support would have been most helpful for you. So if you're able to just spend a few minutes having a think about that and scribble anything that occurs either on the paper or on the post-its, that would be super helpful. you. It sounds like there's some really great discussions going on, but I am conscious that it's quite a long session. So I think we've had a comment from someone on online on YouTube talking about how they're concerned that as their child gets older, their child's going to become more immobile because that's what's happened to their other children. But so that's a really good concern to raise, and I know that as parents we always have anxieties about our children and how things are going to develop. Are people comfortable feeding back from their groups, or would they rather I try to read their handwriting?
So one of the things I found most challenging was that I didn't even realise the link between the pain that I began having. I now realise would have been around about the same time as perimenopause started for me, which was early 40s. I'd had lots of other issues, but not the pain I was getting and still get. And it took till last year and seeing a pain psychologist to realise that it's the hypermobility that's probably been driving everything, and the effect that hormone changes have on hypermobility, and that is probably what has caused a lot of my pain. But the GPs, in my experience, haven't been aware, were seemingly uninterested because it wasn't something they could fix easily. I think, that would have helped if they'd been aware. And we were discussing within our group that going forward, hopefully with all the research that's going on and all the work that yourselves and other agencies are doing, hopefully things will change, because it will filter down for the medics and all the healthcare people to be better educated. So support looks like listening and actually hearing, which I know is something that's really important for Freddie, educating and changing the systems accordingly so that people are properly supported, so that there's a generalised education about the effect that hypermobility can have, and so that everyone is more aware. But I think that takes time, so we're grateful for what you're doing.
What I found most challenging is just being aware of it, and it wasn't really on my radar until recently, because I just assumed that I'd heard of hypermobility, but I just assumed that wasn't me because I'm really stiff. And only just knowing about it now, what I'm finding most challenging is probably linking it up to all of the other things that I have. So it's been really illuminating today, just hearing some of the symptoms and things that I just passed off as being symptoms of dyspraxia, which of course there can be overlap, but still finding it challenging just putting everything together, especially because I'm only just realizing or going down that journey of trying to get diagnosis for ADHD and autism. So the support that would be most helpful is just more sessions like this, I think, and especially in terms of how hypermobility connects with neurodivergence, like you have done the other session, and particularly for me with hormones.
What would help would be professionals listening and understanding and hearing us as the experts of our own bodies, and not dismissing us. So to listen to us. So if we're explaining something about our child or ourselves, to give us the time to hear us, as we are the experts on our own bodies. And so that would be linked to validation as well, because that can be quite empowering and healing as well, is to have somebody to listen, understand, and actually support, and not feel like you're dismissed. What would help as well would be to have access to OTs and physios earlier on, as well as GPs earlier on supporting. More knowledge from professionals, and better access to diagnosis.
I really appreciate everyone sharing. I know it's not always easy, so I'm really grateful that you're doing that. In terms of the GP and the physios, we've got the one-page guide on the tables designed for primary care and GP professionals. So do take those with you just in case they're useful to pass on. Is anyone happy on this table to talk?
Right. Yeah. Okay. Well, we talked a little bit about it, and like other tables have already said, really, it's one of the biggest challenges is just not being listened to, not being taken seriously, and GPs, pediatricians, many medical professions being woefully inadequately prepared to deal with this kind of thing, not joining the dots, not understanding very much at all, frankly. And I'm sure it's experience of many people. The challenge as well of trying to find a specialist or someone who is actually knowledgeable in this area, who does know the links between all of these things. Because, I mean, for myself, I've only just realized today that it's the entire family, not just one child and me. It's actually nearly all of them. And I'm like, it's like, yeah, I won't swear, but we're all left basically. So that's a huge thing, and I think people need to know that a lot earlier to be able to help their family members. So what would be helpful really is the information sharing, getting this kind of information out there very publicly in all doctors' surgeries, all hospital waiting rooms, anywhere and everywhere you can get it, basically, so that people can join up the dots themselves and educate the professionals about it. What else? Having a team of professionals, I think Melissa mentioned as well, about having the OTs, the physios. It's having that team around someone who's suffering to support them with pain, with the mental health aspect of it, and possibly even medication for that as well. Was there anything else? Have I missed something? Cool. Yes, yes. I think I mentioned that. Okay, I think that's it. Okay, off the soapbox now.
I think just to add to that, we were talking about I had a similar kind of realization about a friend of mine who was always labelled clumsy when she was a child, was a contemporary dancer, suffers now with lots of joint pain, and has always kind of put that down to the dancing. But actually, it's probably not only linked to the dancing, and her daughter has autism and is hypermobile. So it's suddenly like making that connection really. And we were talking also about, more joined up working. So, you've got people that are supporting people with a diagnosis, maybe, linked to an autism diagnosis, but actually it's about people being joined up, having that knowledge and working together kind of in more of like a multidisciplinary way.
What I looked at one of the last when I looked at one of the last slides you had about all the conditions and all the issues and all the syndromes and everything interconnected, and anxiety, depression and everything, and just like what we've all talked about here, obviously I don't like labeling, even though it categorizes a person. Labeling for me is for bags, boxes and stuff in the shop. When we go back, I'm not an academic, but I've talked to doctors who are junior doctors now in the system, and I've asked them how they've been taught, and they're not being taught about these things. They're just in that system of conventionalism with regards to, drugs and this and that, and that's all we can do. And then I've also talked to doctors who've been in the system and who've come out privately and are working in certain areas in this country now because the system is fractured and broken. And we're asking people, and to me, I've had issues from my childhood and issues from my adulthood and everything, trauma, being in the forces, and I've seen things. but I've had to deal with it myself, and lucky enough I have. But I'm sort of a firm believer, like Abomake, that most of this is down to obviously our trauma that is embedded within us, in our subconscious mind, and by doing and retraining that we're going to get to somewhere that we get some sort of understanding, most probably love and empathy, so that we can, sort of, I don't know, sort of come from a place of consideration, really. And these things are taught in one other country, in Finland. They're taught from a young age of love and empathy and understanding and tolerance. And we need to teach this to kids in this country, because sometimes the parents can't help them because we're just overloaded. We literally are overloaded in the whole thing. So thank you.
Great point. And I think things that have come out of that really clearly about being understood, being listened to, and that whole point about connection. So connecting the symptoms, connecting the professionals, connecting the support, the services. It's all, unfortunately, things that we do hear a lot. In terms of spreading resources, I can leave some resources with Melissa, and if anyone is able to hand them to healthcare professionals in Wales that they see, that would be absolutely fantastic. Thank you. But thank you for sharing. I know it's not easy. Thank you ever so much. What we wanted to do next, and we are conscious of time, is just to go through some of the things in terms of building a health toolkit, so that there are things that you can do. As a charity, we do have a lot of talks throughout the year. We've got a lot of information on our website, so we're only, unfortunately, going to be able to scratch the surface today. But we will try and give some basic information. I'm really sorry, my mic's gone a bit. Okay, Kim, do you mind doing the talking while I just sort my mic out because it's gone a bit weird?
No worries. Yeah, the diagnostic delay, the not being listened to, all of those are absolutely valid, and they are happening, unfortunately, everywhere. And that's why you have people like us as a charity doing the raising awareness, trying to get to the GPs, trying to get to the hospitals, trying to train the people. And we'll talk a little bit, if we get time, about the quick reference guide and things. But in that interim, we have people systematically falling apart, myself included. It took 11 years to get diagnosed. That's really common frame of time. And if you don't know and you don't have any diagnoses, how do you know how to get better? So the fact that you've got that understanding that something's going on, even if you're not diagnosed, having some sort of toolkit from all different areas is really important to us. And something that our resident occupational therapist, Jo Southall, does in her private practice a lot is building health toolkits with her clients. And she wrote this particular slide for us. And it's something she would advise all of us to be doing. She thinks everybody should have one. And I agree with her wholeheartedly, because those of us that have that slightly more complicated kind of bodies and minds going on, we need a quite an extensive, comprehensive kit of things to help us manage with coping strategies and managing symptoms. Because for a lot of us, it has that multi-systemic issue going on. Is your microphone working now, Lisa?
I think so. Yeah, I'm not sure. I think it's kind of making a funny boom, boom, boom noise, but it's fine.
Do you want me to carry on, or do you want to talk?
No, carry on for a second while I think it might be my hair.
Okay, so we need to be able to think about managing things like acute injuries, or getting coughs, colds and things like that, but also thinking about things like pacing, looking after your sleep, how we manage pain, how we look after our joints, and equally things like how we communicate effectively with a healthcare team. And a lot of the time, you know, we do get pushed around the system, and I hear about it within all NHSs, regardless of where you are in the countries. You know, we all get pushed around from pillar to post, and we could be under a multitude of people, but there is sometimes that disconnect of who talks to who. But being under a multidisciplinary team isn't a bad thing. It's just making sure that we are able to advocate for ourselves, to be able to push and get the right treatments or the right referrals that are needed, that kind of thing. And if you're struggling with diagnoses, and you know, a really nice little phrase is, you know, you think you have a connective tissue disorder, they tend to take that little phrase a little bit more seriously than just, you know, hypermobility. A lot of them have a very old school approach to what hypermobility is. And back in the day, it was diagnosed as benign hypermobility, which actually we know, for those that have it, doesn't feel benign. Yeah, it doesn't feel like there's no issue at all. So this is where we have to kind of start building a health toolkit with a multitude of things. Okay, so I'm just going to move on. So the first one for us, I'm just going to try and get all the things up here. There we go. So I am one of those cheesy people. I'll hold up my hands and say knowledge is power, because it really is. And this is something like with my clients as well, you know, just providing as much information, as much knowledge for them to understand what's going on and why, from that neuroscience perspective, but also with their bodies, because they are so interlinked. Thinking about, you know, specifically the kids zone on the HMSA website, it is written for little ones in their words, so that can be a really useful one if you're caring for somebody who's quite young. It has really nice topics. The link is at the bottom. I believe our lovely link fairy will pop it in the chat on YouTube as well, but it covers a range of topics for the smaller ones. But we do have a multitude of booklets available through the HMSA website as well, which I would always recommend. You know, I've got all of them, and I will still go back to them because they are a really good source of information. But they cover a whole range of topics in terms of the stuff we can struggle with, but how we can manage and cope with things a little bit better. Anything to add on that one, Lisa?
A couple of things. We've got a new Living Well guide coming out next month, so it will have updated and new information in it. And also, does anyone here have sort of primary school age children? So we've got, I'll leave this with you, we've got an in-progress toolkit and pacing toolkit, self-management kit for primary school age children. If you are able to have a look and to give us some feedback on it before we finally send it to print, that would be amazing. So do let us know, and we're always open to doing things in Welsh, so just let us know. Yeah. Yeah, no, absolutely. We'd really like some feedback before we finally sign it off, but it would be impossible. But yeah, absolutely. Great. Thank you. I'll leave the copies afterwards. Brilliant. So,
okay, hopefully.
Can you hear me now, Kim?
I can. You're coming through a speaker. I can hear you at some way or shape or form. That's fine. So we're going to run through some real basic strategies for helping managing pain and fatigue and things. Okay. Now this is Jo and her wonderful pacing strategies. When I went to the NHS and they tried to teach me pacing, this isn't what Jo teaches pacing. It is different. So we was always taught, go and do a thing and go and rest, which is fine to a certain degree, but you never feel like you're getting anything done. So pacing, when it's done properly, and the way that Joe teaches it, is a swap, don't stop approach. So making sure you mix up cognitive, non-cognitive, physical and non-physical items. So if I'm working with a client for an hour, as an example, that is a physical task for me and a cognitive task for me. So I need to be able to do something that switches off my brain and is not too physically taxing afterwards to recover. Recovery items can include things like relaxation techniques, but equally for me, just flopping and crocheting for a while is a way for me to switch off my brain and my body for a bit. And it actually helps with that recovery as well of energy and reduces pain and things like that as well. So it's thinking about things like that. So you're constantly swapping throughout the day. Can actually help you achieve more in the long run, rather than having that kind of boom and bust approach to things. Otherwise, we end up in this kind of perpetual state of pain, stress and anxiety as a result of it, and not wanting to go and do things because it creates pain. So it's enabling someone to do more with the limited energy that they potentially have as well. This is a very basic kind of touch on pacing. She does offer masterclasses and things on pacing, and she talks about it a lot in our webinars that she offers as well. So if you come along to one of her free webinars that she does, she'll probably talk about pacing. She's a real good one for that.
The third Thursday, every month at 7 p.m. Keep an eye on our website. Joe is always online. It's free. It's either just Joe or Joe and a guest. So next month it will be Joy from Marcel Action. In December, the wonderful Kim Clayden, you may have heard of her. In January, we've got a hand therapist coming along. They're open Q&A sessions, completely free. Anyone can sign up. If you can't make it live, we share the recording afterwards. So that's a good free resource if you've got a question. Yeah, it's the third Thursday of every month. So the next one is November the 20th, 7 p.m. And if you sign up online, if you can't make it, because we know it's impossible to find the time that everyone can make, we record them and then the recordings are available afterwards. So even if you can't make it, you can pre-submit a question.
Yeah, so you can pre-ask a question.
Yeah, and also Kim and Joe in January each year for our members do a Living Well series, which will go through some of the things that Kim's about to talk about, which is a 5-week course for members only, and it's in January each year. So that's a wonderful resource in terms of getting started with some of the things we're talking about just really quickly now.
Yeah, we do a whole topic of mental health. We do pain management, sleep management, keeping moving, and a whole Q&A topic spread over a good 5 weeks. And we've actually, Lisa, discussed perhaps making it an hour and a half now, because we always run over so much each session and we get so many questions. Okay. So just really, really basic sleep hygiene. So sleep hygiene is a way of managing sleep. It doesn't mean that you need to be clean, although it's nice to go to bed after a shower or a bath. But there's a real misconception as to what sleep hygiene means. Basically, your routine is really important. We're basically trying to teach our brain, if I do this set of things, it now means it's sleepy time. So it's teaching our brain doing, I have the medication, I relax in bed, I may have my shower, I do, all of those things. As long as we're keeping them very much the same every single night, the brain should learn that that now means it's time to sleep and wind down. So daylight exposure is important for us first thing in the morning as well as at sunset. And thinking about daylight exposure, a lot of the time we spend indoors now. I've been sat inside my boat, my porthole is closed, so I haven't got the daylight exposure that I'll need, so I will feel a lot less awake. No, more tired. Oh, my words. So I won't be as tired tonight as a result of being indoors more, because windows even will filter out so much UV, so we're not getting that daylight hit right at the back of the eyes, which generates certain things like melatonin that make us feel sleepy. So if you've ever been just out in the garden pottering about, a lot of the day, you tend to feel more sleepy as a result of just being outside. We are built as outside creatures, but we're now having an inside world, and it becomes more difficult for us to feel sleepy. For those of us with real kind of fatigue issues, you know, naps are okay. 90 minutes max, ideally, because you'll get a nice little REM cycle in there, which helps with energy and kind of filtering the brain stuff. And trying to do it at least 8 hours before your planned bedtime if you can. So that's why they kind of say no, try not to do it past 3 p.m. if you can. And I plan a nap pretty much every day as part of managing my symptoms. I will absolutely be going for a flop after this to recover some of my energy, because being upright for me with the screen and everything takes a lot out of me with my symptoms. So after I've moved my body quite a bit, I will then go for a little flop. And if you need an energy boost at all, something known as non-sleep deep rest can be really useful. Actually, you can actually have access to my nighttime recording if you want to. I can hopefully the link fairy has that. But things like that can be really useful during the day. But if you search for non-sleep deep rest or NSDR, there's loads of stuff on YouTube that's available. Just like little short 10 minutes, 15 minutes, kind of listen, relax for a moment. It can help boost some energy for you. And blue light filters after sunset. I've got all of my kind of smart devices, like laptops, mobile phones, they're all pre-programmed to have blue light filters come on. I don't know if you've ever noticed, if you have the night filter on, you can get sleepy. If you don't, your eyes are just popped awake. Until you turn it off, they can start to feel sleepy. So it just stimulates the brain and the eyes, and it stops you from feeling sleepy. But we are the only mammal that will refuse to go to sleep when we feel sleepy, and we'll just keep, you know, one more episode on Netflix or whatever it may be. We just keep on pushing and keeping staying awake. So using filters can be really, really useful. And just really briefly on pain management, as I say, this is the basics. There's a whole bunch of neuroscience and all sorts on this, but distraction techniques can be really useful, especially for little ones in pain. It's horrible to see, you know, so if you can try to distract them with nice things to play with and do, then that is absolutely awesome if they can. And, you know, using things like heat and cold is really good as well at the same time. So if they are, you know, doing a jigsaw, writing, drawing, hugging a hot water bottle, for example, at the same time can help soothe, but also can help with the tight muscles, aches, cramps and inflammation, all of that kind of stuff at the same time. Music stimulates certain neurotransmitters in the brain, makes us feel good, but doing distraction techniques also gives us certain feel good neurotransmitters as well, can help reduce pain as well. So all of these things combined can be really useful in terms of managing our stress, but also then that helps with that communication with the brain to reduce the pain signal in the brain as well as the body. So, and things like deep breathing exercises, really hard sometimes for little ones to try and get on board with, but making games out of it can be really good. You know, even just getting the stuff we used to use as kids, where you just dip and blow bubbles, even just playing with bubbles and things like that, or visualizing blowing bubbles, can help reduce pain, anxiety around, and pain perception as well. So little things like that can be really, really nice. Okay. And this is the volunteer we spoke about. This is all kind of the stuff that she uses day to day to help manage their symptoms. Interestingly, she was the one that had 1 out of 9 on the Baton score. And actually she uses splints and braces, insoles and stuff on a daily basis. She's a part-time ambulatory wheelchair user, uses sticks, crutches, all of these things, pacing, fidgeting, compression gear, all of this stuff. So actually she, although has the 1 out of the 9 scale, she's probably the most disabled out of all of us. But she manages her symptoms with a whole host of things that are really useful. And people like occupational therapists are really good at helping you come up with this toolkit of things, because they have access to a lot of information on how to manage these things as well. Anything to add on this, Lisa?
I was going to say, actually, one of the things I think that is important is sometimes being able to say no, which I know it's a really, really hard thing to do. But this particular volunteer this morning said, yeah, I'm really sorry, I can't do it today. I'm just too zonked, but I can do it for you tomorrow. Brilliant. That's great. It's really helpful for me. She's managed her symptoms I know exactly where we are. It is great. And I think it feels hard to say no, but actually it's really, really important. So difficult but vital thing to do, I think. So this is just an excerpt from the self-management folder that I was just talking about for primary school children. We are aiming to do one for other age groups. In fact, when we shared this with some of the volunteers, they went, "Can we have an adult one too, please?" This is something that if anyone is happy to give feedback, as I said, that's brilliant, and I'll hand out some copies afterwards. And then once we've got that done, we'll be able to share that more widely. But I think with young people, it is about finding different ways that they can communicate. And we know that even when they're in school, sometimes it's really useful to have a pre-agreed, signal with the teacher, because if you're 5 or 6 or even 10, you don't necessarily want to have to put your hand up in class, say you're too tired. So you have stickers on the desk, a colour code, signs, whatever, so that actually sometimes you can do things both non-verbally with less energy and possibly more discreetly. I think those things are really, really helpful things that can be done. But this has got some fatigue management suggestions, some sleep management techniques, and a whole variety of things to help young people self-manage and to make them feel like they're a little bit more in control. Perfect. There you go. This was the event we were just talking about with the fantastic Joe Southall. We do have a range of events online. We tend to advertise them about 3 weeks, a month in advance, so do have a look on either our social media or our website. Some of them do have a nominal charge. They're free for all of our members, and members get everything free, journal, everything. But we're conscious that not everybody can afford to pay, so we do have a lot of stuff for free. Yes, Kim, can you go back one slide? Sorry, I think someone wants to take a picture. Fab. Excellent. You can go forward now. So we know that most of the people in the room aren't professionals, but I think there might be a few online. So we just wanted to share some information about things that we do for professionals. So with people affected by hypermobility, we're all about helping people to self-manage their symptoms and improve their quality of life. But we also absolutely want to spread the word amongst professionals to raise awareness. So we do have professional membership. We do have events and resources that they can access. And they do support us with research and either participation in or sharing their own research. This is the piece of paper that's on the tables, which I mentioned earlier, which Kim might want to talk about in more detail. But if any of you want to take copies, share them far and wide, that would be fantastic. Kim, did you want to, since Kim is one of the co-creators, so Kim, did you want to talk any more about it?
Yeah, so we know hypermobility in itself is very complicated and complex. And we know GPs, rheumatologists, they all try and shy away from it. So we're trying to make it as easy as possible for them to look at something and go, okay, maybe something more kind of multi-systemic is going on. There's a multitude of things going on here. And we're trying to break it down as easy as possible. So the stuff that we talked about today in terms of like genetic testing, the Baton score is not the be all and end all. And that's why we've got our little evidence of hypermobility 5-point questionnaire. We've talked about the spider, the neurodivergence and mast cell, but then there's also these links to the diagnostic criteria for them, how they can make a management plan, and what they can do. And there's further resources to try and make it as simple on a piece of paper to be able to diagnose. GPs should be able to diagnose. This is what we're trying to do, and it's trying to push it out there as best we can. So the more we can share as far and wide as possible, the more we can get the people diagnosed early, rather than having that issue of them deconditioning, like myself. Like, it's very common in our community because it takes so long to get the diagnosis. The sooner we get diagnosed, the sooner we can get them physioing and rehabbing and working on all the things to help them manage going forward as best as they can.
Absolutely, and we can't reiterate that enough. In theory, and we know it's not always that way, but in theory, GPs can diagnose and they can then appropriately signpost you onto the additional support that you need. So here are just, in case there's any professionals online, the links for professionals. So there's a clinician's guide, which has got a huge amount of information for professionals. There's a downloadable leaflet, which is one of the ones on the table that can give patients, and there's the link there, the online link to the e-version of the guide that you've got on the table. Fantastic. I think, yes, I think thank you for your patience. It's been absolutely brilliant having you here. We have got a bit of time for questions, but this is how you can get in contact with me, and I think that Kim has got her contact details available as well, in case you want to get in touch with her directly. We will go on to Q&A, but I know that I'm kind of running over, so if anybody does need to go, that's absolutely fine. Thank you so much again to such a fantastic team for having us here today and for coping with all the tech issues and the internet and the mic and everything else. So thank you so much. Does anybody have any questions? Yes. Yes, of course you can. Yeah. Oh, yes. Kim, that might be a question for you. How does pacing work for people with ADHD and hyperfocus? And this is something, because a lot of people at the HMSA are neurodiverse, we are very familiar with, but I'll let Kim handle this.
Yeah, I have the same issue myself. So I have to set alarms. Otherwise, I will just keep going all day and forget to eat and drink and just hyper focus through the day. Especially when I'm doing study and things and you're in that zone. So Joe talks about things like micro braking or micro breaks. So every so often, just checking in with yourself. 20-minute alarms are quite good. And also, or an hour alarm if depending on your energy levels and fatigue, but just doing a real good check-in, quick scan of your body. Is my head hurting? Have I actually had something to eat? Have I actually had something to drink? And sometimes people will put checklists on their wall, just really simple. Have I had a drink? Have I had something to eat? Have I stretched? Is my head okay? The usual things they may struggle with. And just having a check through of those every time an alarm goes off to just break that concentration. We can soon get back into the swing of things, but we must check in with ourselves. 20-minute alarms are quite good in terms of pacing, and then going off and doing something else for 20 minutes and then coming back to that. So you're using different muscle groups, using your brain in different ways so you can recover in different ways. I'm one of the lucky people. I can do about an hour before I need to do something different. But by that time, you know, if you've got a bit of a niggly headache, get that sorted, get a drink in you, get some food. Because if you keep hyper focusing, you get to the end of the day, you've got the migraine and you're a dribbly mess on the floor. So we need to try and be as proactive with that management as possible. We do find though, because brains are amazing but amazingly annoying at the same time, that you'll start to, if you start to ignore your alarm after a little while, please change the alarm sound. So the brain starts to kind of go, oh, okay, my alarm's gone off again. And then if you start swiping and carrying on, please change the sound, because brains do that. They're a bit annoying for that. So hopefully that's useful.
Does anybody else have any questions? Always get in touch with us on email. We do have a helpline that's free. It's manned by volunteers, so they won't pick up the phone straight away, but they will get back to you. So do keep in touch and let us know if you need anything. But thank you so much for coming. It's been absolutely brilliant to meet you all. And if you do, somewhere around, there's a sign-up sheet. If you do want to get our e-news, then it will give you reminders for the events coming up that are free and bits of research and things that are going on. So thank you again.